proof of concept to a program level utility demands not only a single system but an integrated systematic approach. However, resource limitation, fragmented service delivery, as well as workforce shortage currently undermine the readiness. So this session will interrogate all the technical specifications, operational workflows, and the governance structures which are essential to implement this genomic testing at population level. I now request our eminent chairpersons, Dr. Sonu H. Subha ma'am, Professor and HOD, Department of Community Medicine, AIIMS Bhubaneswar, and Nodal Officer, NTEP, onto the dais, please. And may I now request our second chairperson, Dr. Manoj Kumar Panigrahi, sir, Professor, Department of Pulmonary Medicine and Critical Care, AIIMS Bhubaneswar, to chair the session on technology, innovation, and system preparedness for genome testing of MDR-TB.
A very good morning to everyone. It is nice to see everybody present here who are eager to learn. And after that session from Dr. Dheeraj, it was very encouraging to note how the technology has advanced and the enthusiasm and positivity of the technology to be able to get targeted investigations, molecular investigations, and then try to find mixed lineage and targeted treatment. Very promising, very enthusiastic, very good. But on the other side, along with technology, we also have the systems preparedness. Even though our system have improved over the years because of polio eradication, because of COVID, now we have at least TrueNat and CBNat at many places. Yet the technology has really not seeped into or penetrated into many areas. So the challenge remains, whether the system is prepared, whether we can transport the samples, how many tests we can do. It was very nice to hear about from Dr. Our PR Mahapatra also, that he said that they're doing targeted therapy in lung cancer. And it's so nice to know that, and it's really useful for the patients. But if you look at TB, are we prepared? What is the burden of TB in our country? It's extremely high. Do we have enough facilities to do that? So I think this session is very important to consider all those things, because it's talking about technology, innovation, and system preparedness for genomic testing of MDR-TB. And it is my pleasure to invite Dr. Sonali Sarkar, Professor of PSM from JIPMER, Puducherry, who's MBBS and MD in SPM. She is chair of the Report India Consortium, constituted under the Indo-US Vaccine Action Program, with 9 Indian and US institutions, jointly funded by DBT and NIH USA, ICMR Center for Advanced Research for the project titled Symptom Agnostic Screening in High Transmission Settings and Characterization of Subclinical Tuberculosis in India, Host and the Pathogen Factors, Clinical Coordination of INTGS, completed 2 ROI grants of impact of TB on pregnancy and predictors of resistant emergence evaluation in multi-drug resistant tuberculosis patients, contributed to the WHO's consolidated guidelines in tuberculosis and undernutrition, has more than 125 publications in peer-reviewed national and international journals, and she was the JIPMER Faculty Research. She also has won the JIPMER Faculty Research Award for Clinical Sciences for 2023. So it's an honor. Over to you, Dr. Sonali. Thank you.
Thank you so much, ma'am, for that kind introduction. And it's an honor for me to be here today. And I thank the organizers for inviting me to this forum. Orissa is my home state, but we need Jagannathji's kripa to visit Bhubaneswar, especially Puri, and Sri Nandishji's intervention in between, who got me here today. So thank you very much again. Today, we have had a lot of discussion on tuberculosis, the challenges and all. We know TB is a very difficult disease to manage. Since time immemorial, we are trying to fight this disease but haven't succeeded. TB bacilli is a small organism with only 4.4 million base pairs of genome, and we human beings with 3.2 billion base pairs are unable to control this. So it's great opportunity for us, and this conference gives us a platform which has all possible minds put together, starting from policy makers, program managers, clinicians, basic scientists, epidemiologists, everybody together. I think we need to come together and put our minds together against fight against TB. So one of the tools that can be used for this control efforts is the genomics. So I would be discussing about the translational opportunities of TB genomics. So from genomic insights to better outcomes in tuberculosis. So we are not saying that the old tools that we have in our armamentarium are not useful. They are, but we should be open to newer tools as well. And genomics is one of them. So this will be the outline of my talk, and pardon me if I am repeating a lot of things that have been said since yesterday and even today morning. So out of the 10.7 million people who developed TB in 2024, about 1.5 million incident TB cases were isoniazid resistant. So yesterday we heard that isoniazid resistance is more common than rifampicin. So of this 15 lakhs, about 4 lakhs had developed multi-drug resistant. And more alarmingly, and 18% had pre-extensively, pre-XDR TB, which is resistance in addition to the first line to at least one tested fluoroquinolone. So we have heard this data earlier also. India contributes to nearly 1/4 of the global TB burden, but 33% of the MDR TB burden. So where are we in terms of TB control? We have had significant achievements. Definitely a 21% reduction in TB incidence and 28% reduction in TB deaths is remarkable, commendable. But it is much less than the expected NTB goals of 80% reduction in TB incidence and 90% reduction in TB deaths. So where does the MDR TB and ultimately genomics come in? If we are able to treat TB patients, diagnose them early and treat them effectively, we are able to break the chain of transmission, prevent further infections, and also reduce the adverse treatment outcomes like death. So early detection is important, but more important is appropriate detection. Appropriate detection where we know the pattern of resistance so that we are able to treat adequately. Unless we treat adequately, we will not be able to reduce the treatment outcomes nor the transmission from those cases. So we have heard a lot about the diagnostic challenges in TB elimination. I'm not going to repeat many of those things, but just to highlight the 2.7 million TB cases were either undiagnosed or unreported in 2023 globally. In India, about 3 to 4% remain undiagnosed. And as was mentioned by Behra sir yesterday, EPTB and other possibacillary TB like TB in children, PLHIV in pregnant women are hard to diagnose. And also the increasing burden of NTM infections that was raised yesterday. So delayed diagnosis and inadequate or inappropriate treatment is one of the challenges that is becoming an hindrance in achieving the NTB goals in our country. So these are the classes of testing technologies available as per the WHO current guidelines for initial tests of TB diagnosis with drug-resistant detection, and also without drug resistance. So we have a lot of molecular tools now available like Expert, TrueNat, and many more have come up now that were mentioned yesterday also. So these are the ones which are available. But we also know the limitations of the current diagnostics. When we try to diagnose DRTB through culture, the most major problem, even it was mentioned today, that PDST, the phenotypic DST, is labor intensive and also time consuming. It moreover, it requires the biosafety cabinet, BSL-3, culture contaminations can happen, and the turnaround time is very high, so which will not ensure an immediate initiation of appropriate treatment. So therefore, we have a number of molecular diagnostics, but the molecular diagnostics too have challenges. What are they? Only predefined genetic mutations can be identified through these GeneXpert or TrueNAT. Incomplete drug resistance profiling, so we do not know the complete picture of all the possible resistance to all the other drugs as well. Lower sensitivity in case of the possibacillary pediatric and extrapulmonary TB, and also this requires specialized instruments, stable electricity. Where we have TrueNAT, which is not so specialized, but the process is a bit complicated, a two-step process where you have to extract DNA before feeding into the RT-PCR machine. So extraction of DNA is not a very simple step which can be done by our laboratory technicians at the primary level of our health facilities. So there also are the challenges. And of course the cost, and this do not provide enough epidemiological information which will tell us about the lineage, the strain typings, the transmission patterns, and the overall genomic diversity is not known from these molecular diagnostic tests. So that is where genomics comes in. Genomics for TB helps us understand the bug clearly. If we don't understand our enemy, how do we fight it? We have to know who is our enemy. So we have to understand the biology and how the host responds to this bug. We, as of now, have very limited understanding, and genomics is expected to help us in this regard. But more specifically, genomics will help us in predicting drug resistance, help us in tracing TB transmission, also elucidate the host pathogen interactions, discover biomarkers, advanced precision diagnostics and therapy. Not going into more about that because we have had multiple discussions around this point. But also understand the pathogen evolution and accelerate the drug and vaccine development. So this is a summary slide for the evolution of the TB genomics starting from 1998, when we had the first complete MTB genome described, and then on till 2020 and present, we have the next generation TB genomics, which are expected, if rolled out and if are utilized in the program, would help us achieve what we call as precision medicine, and therefore better treatment outcomes and achieve TB elimination. So these are the major genomic approaches we have heard. Dr. Behra was mentioning about this yesterday. Whole genome sequencing, comparative genomics, transcriptomics, transposon sequencing, host genomics and transcriptomics, and ultimately the systems biology, which incorporates all the omics into along with the clinical data to understand what is happening, not just in silos, but overall in the host or in the pathogen. So this is a little bit in detail about each of these methods, but I'll not go into very much detail. Whole genomics actually gives us a complete resolution, genetic resolution of the bug. And therefore, we can identify many known mutations or even novel mutations which lead to drug resistance, but has limitations. It has lower sensitivity in low bacterial burden specimens, and of course the cost is very, very high. So we do have challenges of incorporating this into the program. We will have a little more in-depth discussions, I hope, on this, how to incorporate into our program. But I always feel wherever genomics is possible, wherever we can do, we should do. And probably your state has been, our state, I should say. I'm in Pondicherry, living for last 25 years, but I still am an Odia by birth. So our state, if has been chosen for implementation of use of genomics for UDST implementation, we should accept it and try to find ways of how to implement it. The other methods are metagenomics. Again, Sir had discussed a little bit in about these, so not going into the details. Targeted NGS, WHO has already endorsed as of 2024 this method for rapid detection of resistance to 3 of the drugs which are in the BPAL-M regimen. BPAL-M is the short regimen for treatment of MDR-TB, which has actually increased the treatment effectiveness, and the cure rate, success rate is almost reaching 75 to 80%, which was earlier, as Dr. Behra was showing, MDR treatment success was very low, about 50 to 53%, but with BPAL-M, it has now reached about 75 to 80%. But we have started noticing resistance to these drugs as well, and WHO recommends use of targeted NGS to diagnose this rapidly, to bedaquiline, linezolid, and moxifloxacin. So these are more accurate than the molecular WHO recommended rapid diagnostics like GeneXpert or GeneXpert Ultra, or even your TrueNat. So TNGs can detect resistance to new and repurposed drugs, and WHO recommendations are now to use this as a follow-on, not as UDST, but as a follow-on. So if you have diagnosed a case of TB and you have done GeneXpert and you have found resistance to one drug, to rifampicin, then better go on for, now we are doing LPA, but this would be a better choice than LPA because we are able to diagnose resistance to many more drugs, and more range of mutations can be identified. The diagnostic performance is quite good, about 94% sensitivity and 98% specificity, but it has limitations too. It can identify selected gene targets, and there can be some instances of the primer or probe binding site dropping out, and some missed resistance can happen. That is why the sensitivity is 94% and not 100. No test till date has such high specificity as 100, so sensitivity. So we know there might be some misses also. So these are the targeted NGS tests that has been approved by WHO in 2024. It is the Deeplex, Ampor TB, and TB-Seq. And these are the drugs that the resistance to which the tests can identify. So now coming to the translational opportunities in TB genomics. We need support of the basic research, genome sequencing, which help us in gene discovery, discovering genes which are related to mutations which are related to drug resistance and therefore are able to predict drug resistance. This can help us in rapid diagnosis, not wait 8 weeks or 6 weeks for the phenotypic DST results. So rapid diagnosis, treatment optimization, and also in public health surveillance, and ultimately improving the treatment TB control. So some of the solutions we will go through now. We have discussed at length about the precision diagnosis and drug resistance predictions. Whatever the limitations be, it is a good tool which is better in many drugs than the phenotypic DST. So TB genomics have enabled rapid detection using the molecular assays, targeted sequencing, and whole genome sequencing. These are the applications, the genes, many of the microbiologists here would know better than me, the genes which can be associated with resistance. The translational impact is again detection very quickly within days of an early identification of MDR and XDR TB, and therefore personalized treatment. Sooner or later we have to go for this. We cannot have one size fits all forever. When the TB burden was very huge in the country, when we started the program way back in 1962, even in RNTCP in 1992, 90s, we had very huge burden. Our health system was not so strong. Technology-wise, we were much behind, and therefore we had to have this one-size-fits-all treatment so that every patient at every PHC was able to get a standard treatment, at least a WHO recommended standard treatment, and ensure cure. But now we have moved far ahead. We have much better technology. Our health system is much better, at least in some states. We see in Tamil Nadu, in Pondicherry, the health system is so well geared up. So wherever this, and of course our state is also doing so well in last few years, I have been out of Odisha, but we can see the overall development in Odisha. And of course, this is reflected in health system as well. So wherever we are able to adopt advanced technology, we should open up and try to accept, at least in a pilot manner, this implementation of new technology, which can help us in providing precision medicine, which would of course ultimately help the improvement in the treatment outcomes and achieve NTP goals. So this was in brief about how what NTGS has been doing, its contribution, but I'll not repeat what Dr. Anish and Dr. Dheeraj have so eloquently presented about our ongoing project. The next area that TB genomics can help in is tracing the TB transmission and investigate outbreaks. TB remains epidemic as an endemic, but we are having outbreaks as well. As we are able to control more and more, we are with the 100-day TB campaign, we have diagnosed so many cases and treated so many, our burden is coming down. So now we have outbreaks which we are not able to identify and contain adequately. So genomics helps us in understanding the links in the transmission, which our conventional epidemiological studies do not tell us. Because in conventional epidemiology, what we do is contact tracing. But in TB, we do not know when a TB case had infection and from where. Because a case of TB who's diagnosed today may have been infected in his or her childhood. As a child had latent TB, and it is a reactivation and not a recent infection. So unless I'm able to differentiate whether it is a reinfection, reactivation, or a recent infection, so I'm not able to take adequate measures. So the contact tracing has absolutely no role in TB in the present context. But if we do genomics, we can compare the strains between the cases, and therefore we can identify the links in the cases from whom the disease was transmitted to whom. So once I know the link, I know the chain of transmission, I can take steps to intervene and control. First, identify outbreaks and then contain outbreaks and have evidence-informed strategies for prevention. So the key applications for this is identifying transmission clusters, identifying recent transmission and differentiating it from reactivation, then to differentiate between the community and healthcare associated infections. Especially it is important for healthcare professionals where we are transmitting disease to a patient or we are getting the disease from the patient. There is again translational impact where it will help us control TB better in a community. These are studies, examples, I'll not go into the detail, where transmission studies have actually helped in different countries. This is a study from China. These are being used, and not only in developed countries. This technology is being used to identify the transmission chains and also guide the prevention strategies. Next is the molecular epidemiology for public health surveillance. It's a one step ahead of what we do in containment of clusters. We are able to identify the strains, the lineages. So where conventional epidemiology has limited resolution in identifying TB transmission, here we know the transmission, we know the transmission of drug-resistant strains, and also through the identification of the lineage, we are able to identify and early identification of transmission hotspots and therefore control. So these are again studies, examples of studies which have utilized genomic tools for whole genome sequencing for identify. This is a study from NIRT, Chennai, led by Dr. Siva Kumar, who was one of our, he's a member of the INTGS group, and by Dr. Somya Swaminathan. So they have found that there are novel resistance mechanisms, and so there is a need for region-specific diagnostics. That is what they are recommending. This was published way back in 2017 in Clinical Infectious Diseases. So the public health surveillance of tuberculosis, which is very rudimentary as of now, needs upgradation, and this tool can help us in this regard. So advanced precision diagnostics and personalized therapy, again, we will continue this discussion, but this is the need of the hour. Again, these are some of the examples where we have used omics and to personalized TB treatment successfully. So these are examples from India. Again, not going into the examples. Another major area of use of genomic technology is drug and vaccine development. So the emergence of MDR and XDR TB, now we know, all of us in this room who are working in TB have felt the necessity of a good vaccine, because we know BCG is unable to protect against TB in the adults. So the conventional drug and vaccine development, whatever pipelines are there, are time consuming, cost, and often hampered by incomplete understanding of the MTB biology. So genomic solution in drug discovery, it can help accelerate the discovery of newer drugs by identification of essential genes required for bacterial survival, virulence determinants, critical metabolic pathways, and novel therapeutic targets. In case of vaccine development, the comparative genomics enables us the identification of conserved antigens, the virulence associated genes, the immune evasion mechanisms, and also lineage specific genetic diversity. So this, of course, has a lot of translational impact. It will accelerate the identification and validation of novel drug targets, as well as enable the development of broadly protective vaccine candidates. These are again examples of studies which have done mapping gene by gene, single nucleotide variation in large numbers of MTB genome, and how this has a support, it can help, has the potential to support the vaccine and drug development. Next, we need to harness the global genomic data. We know that WHO catalog is there, we are using, but as was told earlier, we do not have a good biorepository in the Indian context, which the INTIGS is now changing. Now we have huge data, the genome sequence of 25,000, and it's counting, it's going up, the target is 32,000, and a huge repository of the strains, which will help us, contribute to the genomic data. And of course, we learn from what is happening globally and learn from our own data. So this is about reimagining tuberculosis control in the era of genomics. The case of global investment, so everybody is coming in the picture. India is actually the focus when it comes to tuberculosis. When it comes to the burden, actual burden, the number of cases per lakh population, India is not the highest. Countries like Philippines, Indonesia have much higher burden, of somewhere around 600 patients prevalence of per lakh population. But we have the largest numbers, absolute numbers of both TB cases and also drug resistant cases. So we have to be the leaders in TB control, because the world is watching us. So there are translational opportunities. There are challenges. We have tools, newer tools. What we need to do is be open to technology and start exploring where and how we can use these tools. Only when we are open to acceptance, we will ultimately, because it is technology, the country is growing so fast, we have to come to terms with technology in TB programs also. So not going through these details, we have spoken of all these genomic opportunities. The future priorities would be a point of care genomic testing, because the technology is becoming simpler and tabletop equipments have come. There was a time we never thought of having a PCR machine tabletop, even in the remote rural areas, in resource poor facilities where PCRs can be done in real time, but it is happening now. So, but we need to develop many more point of care genomic testing, portable sequencing platforms like Nanopore, which can go to the remote areas, AI assisted genomic interpretation, which is happening under INTIGS, what Dr. Anish was talking about, multi-pathogen genomic surveillance, and also integration of genomic data into the clinical decision support system and also the reporting system in the program. So this is the final slide, what we have the translation opportunities of TB genomics. From conventional diagnostics to advanced genomics, advanced genomic and future precision, from sputum microscopy, culture and molecular tests to whole genome sequencing, use of bioinformatics in AI/ML, integrative insights and data repository and knowledge sharing. This is where we are advancing. Limitations are there. We do have advantages as well, but it will ultimately help us in early and accurate diagnosis, precision drug resistance detection, and appropriate and adequate treatment, transmission tracking, personalized therapies for TB patients, surveillance and policy impact, and finally, research and innovation. So the journey continues. We try to harness the power of TB genomics to bridge the gap between the diagnostics and precision care. These are the references. Thank you for your patient hearing.
Thank you, Dr. Sonali, for an excellent presentation. I'm sure you all really liked hearing that. Very promising, and we all know that we are going for TB elimination, and with the conventional things that we are doing, it is not possible. So we do need technology, and especially the genetics is coming in a big way, whether it's NGS, whether it's WGS, may be difficult now, but then we need to improve the detection, especially of drug-resistant tuberculosis, and treatment, and we have to have very good treatment outcomes if we are to eliminate TB. So for that, I think genetic sequencing has a major role to play. However, Dr. Sonali very categorically pointed out, NGS is so good, but it can only detect limited number. I think Dr. Dheeraj said 72 sites are there. So there will always be deficiencies, but then we can at least, but it's a progress. So basically, how the genetic sequencing can help in contact tracing. I remember in 2000 when we were in working for polio program, China had actually eliminated polio, and suddenly they found 2 wild polio virus cases, and they did countrywide, like, mopping up. And when they did genetic sequencing, you know where the virus was from?
India.
Yeah, Uttar Pradesh. There were business people traveling from India. So that's what genetic sequencing does. And we can, as she talked about global repository, Indian repository of viruses, we'll know exactly where they're coming from, which outbreaks are being caused by which, where it is getting transmitted from. We can actually cut down those chains of transmission. Excellent work genetic sequencing can do. He talked about translation sequencing and how it can also be used for basically detecting foreign strain, like Beijing strain. Hopefully we don't have that, but Beijing strain, high virulence, high infectivity, we don't want that, and we can always see where it's coming from. And of course, for vaccine and drug development, it will be a very, very good thing. And eventually, with the magnitude of TB cases that we have, POC, point of care testing, has to come. And to make genetic sequencing, or at least trying to see MDR TB, the type of lineages at point of care, because the magnitude is too big to just have few labs and then, send everything there. So I think it's a long way, but we're all dreaming along with the people on the field who are doing the basic things of detection and giving dots to the high-end labs like INGS and Dare to, I think, IRAD TB. So with all these things, we are very happy to know that things are advancing from both the ends. Eventually, we have to marry this technology and groundwork to have success in TB control. And I'm very happy. Thank you so much, Dr. Sonali, for this presentation. So I hand over to Dr. Manoj for introducing the next speaker.
Anything from the audience wants? Any questions for Dr. Sonali? Or else we'll move to the next talk. Okay. So next I would like to invite Dr. Rohit Kumar. He is currently working as Associate Professor and Head of the Department of Pulmonology, Critical Care Medicines and Sleep Disorder at Vardhaman Mahavir Medical College and Safdarjung Hospital, New Delhi. And he has the lot of fellowships and other degrees, which all of you can see here attached to his credentials. And without discussing much about the thing, we should move forward to the talk. Let's listen to Dr. Rohit.
So good morning, everyone. I've taken a topic of universal drug testing via targeted NGS in tuberculosis. And a lot of my slides would seem a bit repetitive, but it's to build up the topic. And finally, I'll discuss 5 cases, which, as clinicians, we would have seen in our OPDs, and how this new technology would drastically change the management of all those cases. So what did India's drug resistance survey reveal? 1 in 16 patients have MDR-TB, that's 6.2%. 1 in 35 new TB patients has MDR. So saying that, MDR will only develop in patients who've earlier been treated for TB, no, not going to happen. You're still going to miss 2.8% of your patients. 1 in 9 previously treated patients had MDR-TB. Nearly 1 in 3 TB patients had resistance to at least one TB drug, that's 28%. 1 in 5 MDR patients had fluoroquinolone resistance, that makes it pre-XDR. And 11% of new TB patients had isoniazid resistance. So this is just, the resistance survey, and, the data that was shown in the morning is even more. Mind you, they took only new patients. They did not take these old patients. So what are the clinical implications of this? Well, 1, drug resistance is common even in newly diagnosed TB. The past treatment alone cannot identify all resistant cases. Possibly the new ones that we are picking up can also have MDR. Universal drug susceptibility testing, UDST, is essential. And I'm going to build up on this topic a lot more. Now, rapid molecular diagnostics really improve, not just for diagnosis. I mean, as a diagnostician, you want dil mange more. You need more and more data. But I need it more because my patient's management is going to change because of this. And treating TB without DST is actually a gamble. You don't really know what you're doing. You don't really know whether your drugs are going to be working. It's actually a gamble. And you're not gambling with yourself, you're gambling with a patient's life. So why targeted NGS? Now what targeted NGS does is it amplifies selected resistance associated genes. It detects resistance to multiple drugs simultaneously. It sequences the entire gene and not just the hotspot. So yesterday Mahapatra sir raised this point. He said when you're doing gene expert, you're looking at hotspots. But once you're doing targeted NGS, you're not just looking at hotspots, you're looking at the whole genome. It identifies specific resistance mutations accurately, and that's something we really need. And it detects resistance to newer and repurposed drugs. So, this technology has been evaluated by WHO. They have started to accept it. We too need to accept it. So there are products which met the WHO performance criteria for implementation. They are able to detect, they're able to work in the field setting. So you had 3 which are there, the Dplex, which is from France, the Ampo TB, the Oxford Nanopore 1 from United Kingdom, and the TB-Sec from Hangzhou Shengting, China. I'm really hoping India is going to have one too. And really, we've done the groundwork. I was really impressed by the groundwork that has already been done, and possibly we're at a stage where we're going to have an Indian company also coming up with this test, Make in India. So this is, the WHO, mind you, these companies claim that they test many, many drugs, but these are, the drugs that have been validated by WHO. So Dplex gives you a better one as compared to Ampor and TB-Sec. Now let's talk about Dplex. It has a 26-plex amplicon sequence targeting 18 genes. Resistance identified using species is identified using HSP65. Genotyping is done. It works on the Illumina platform. Most scientists are working on Illumina actually. It does cloud-based automated analysis. And this is where I think you can link it to an app. This is something that many people are talking about. You give me too much of complex data. How, as a clinician, will I decide on a regime? Give me an app which will interpret this data for me and design a regime. At a field level, you don't have to learn up regimes for every resistance. You can use an app for it. In fact, one of our colleagues from NITRD, they actually made an app to decide how to use MDR. So a pregnant, less than 14, more than 14, fluoroquinolone resistance not there, just enter that data and you get a regime, either BPAL or BPAL-M or whatever be the regime. You can design this regime simply through an app. So if you have these cloud-based platforms, the data can seamlessly be transferred to an app, which will tell you what is the good regime for this patient. And this has the broadest WHO support. Then you have Oxford Nanopore Ampor TB. It is 26-plex amplicon sequencing. Again, uses HSP65 built-in internal controls. It's a fully automated local analysis. So in areas where you do not have internet facility or internet facility is not reliable, this could be used. And in the Indian platform can develop both these technologies. And it can be integrated and highly automated reporting can be done. The same with TB-sec, species identification using 16S as well as HSP65 genes, operates on Oxford Nanopore, powered by the TNGS software, and it interprets data which is given in a web app. Now this web app can also be integrated to an app, and on a phone itself you can decide on these regimes. So this is just a small technical comparison, but what we can, if an Indian app is being developed, I would love to have one which has cloud-based as well as local analysis for wide usage throughout India. Now, this is the limitation and challenges. Currently, a conditional WHO recommendation only. There is significant infrastructure and implementation challenges. There's a high sequencing cost. The reagent procurement is a bit difficult. There is limited validation for some second-line drugs. I usually, when I show this slide, I feel very unhappy. But today I'm very happy because now I'm standing at a policy conclave where this policy is going to answer all these questions. It will tell us whether it's just a conditional recommendation. If our program, if our pilot program shows it is good, it will evolve into a strong recommendation. If our policy can, implement this, it will show that all these significant infrastructure and implementation challenges can be overcome. If we can do it in a district, we can show what are the costs, and if you do it on a large number, actually the cost will come down. There is limitation validation data, but if we do this policy, if we implement it, we will show that there is good data. Either way, we will show some data. So I'll talk of the clinical scenarios that I face. This is a concern that I have. Are we over-treating some patients? So look at this patient, a 28-year-old male, smear positive, initial CBNAT, MTB detected. So rifampicin resistance not detected. What do you do in such a patient? You start them on HRZE followed by HRE. This is the continuation phase. This patient developed ethambutol eye toxicity. It happens. Patients lose their vision. If not caught early, it is progressive, at times irreversible. Imagine a 28-year-old male is not seeing because I treated him for TB. That's the problem. Are we over-treating it? Do all patients require ethambutol during continuation phase? So, when I was an MBBS student, we were told HRZE for 2 months and followed by HR. Then why did we make it HRE? Well, the reason for that was there is isoniazid monoresistance. A lot of, 1 in 5 patients has isoniazid monoresistance. So if we give them only HR during continuation phase, we're giving them only one effective drug. So just to overcome that, we made it HRE. So this is the thing, the HRE blind spot in India. High isoniazid background resistance, because of which we are now giving HRE to all our patients. Possibly they don't need it. Possibly they don't need that ethambutol. The consequence is prolonged ethambutol exposure, which carries a significant risk of severe dose-dependent optic neuritis. And that can result in decreased visual acuity, irreversible at times. So imagine I have this system now. Imagine I have targeted NGS available to me. Day one, I know ethambutol is, isoniazid monoresistance is not there. Rifampicin monoresistance is not there. So why would I put this patient on HRE? I would put this patient only on HR, not expose this patient to ethambutol, not expose them to eye toxicity. Mind you, I'm talking of patients who are drug sensitive. Drug sensitive by our gene expert. I don't want to overtreat my patient with a drug that would harm his eyes. Then another thing, the INH turnaround trap that I call. So you have MTB detected, a 32-year-old male, smear positive, MTB detected, rifampicin resistance not detected. This is also our drug-sensitive TB. So we start this patient on HRZE followed by HRE. Then there's a reflex order of a first-line LPA. Let me tell you, in ground reality, this rarely happens. But still, you get an HR, you get an LPA done. LPA comes out on day 24. LPA comes out, CAT-G mutation positive. There is high-level isoniazid resistance. Impact, patient received INH for 24 days, useless, unnecessarily exposed to a drug, which we could have completely avoided. So if you have, if we can overcome these treatment delays, if we can pick up INH monoresistance early, it would change our regime and not expose my patients to drugs. Mind you, all drugs have side effects. So how NTGS would help us? Well, parallel amplicon sequencing simultaneously will target all these genes. You'll get the result in 24 to 48 hours. You'll have immediate treatment tailoring. So instead of HRZE, I would put this patient on levofloxacin, rifampicin, ethambutol, and pyrazinamide. Stop the drug which is not useful. from day 2 itself, the patient is on a therapy that's going to work. And the clinical outcome would be a rapid sputum conversion that would be expected. Now coming to another clinical scenario that we face. Again, this is a patient who is, rifampicin sensitive. We call them drug sensitive. There is the hidden pyrazinamide resistance that I call. Now what happens is, if you look at the baseline diagnostics, rapid PCR will detect RIF sensitive strain. Patient will be started on HRZE. 8-week checkup, patient remains culture positive. What went wrong? We did a phenotypic DST for pyrazinamide. It takes 2.5 months. And mind you, that is quick. That is the quickest that you'll get the results. 2.5 months, you get to know pyrazinamide was a useless drug. Pyrazinamide, mind you, causes a lot of liver toxicity. A lot of our patients who have drug-induced liver injury, one of the culprit drugs other than rifampicin is actually pyrazinamide. So this is what the pyrazinamide blind spot is. Mind you, gene expert cannot pick it. Even LPA is not very good at picking it up, right? And phenotypic things are also ideally not good for pyrazinamide. So pyrazinamide, I think, targeted NGS is actually a boon. So this is what I see. LPA and PCR probes rely on hotspot mutations because the NCA mutations are scattered across 561 base pairs. The hybridization probes suffer from extremely low sensitivity. Targeted NGS, on the other hand, sequences the entire coding region. And then that's why it can pick up this resistance very well. And then there is, why give pyrazinamide to a person who has resistance? Why expose this patient to hepatotoxicity? So this is the idea that if you have this drug, if you have this test, it will make your patient's life safer. I mean, I hope I can drill this point across. Making patients' life safer is a very important target for a clinician. Now let's look at, so these were all 3 cases were those who are, as per gene expert, categorized as drug-sensitive TB. Now let's look at MDR TB also. You have an MDR patient diagnosed without FQ data, without fluoroquinolone data. Patient 45-year-old male, rifampicin resistant on gene expert. Now the clinical dilemma that I face in this scenario is whether should I start this patient on BPAL-M regime. Now for me to start BPAL-M, I have to be sure that fluoroquinolone resistance must be ruled out. So sending a phenotypic DST for bedaquiline and linezolid will take 4 to 6 weeks. What do you do in these 4 to 6 weeks? You have a patient who is MDR, who is spreading this. What do you do in these 4 to 6 weeks? Stop BPAL, not give BPAL? That confusion in your mind. Imagine I get a report like this on 24 to 48 hours. 24 to 48 hours, that's amazing. 24 to 48 hours, I get this report. Well, as expected, rifampicin resistance, but fluoroquinolone susceptible, bedaquiline susceptible, linezolid susceptible. It takes me just 2 days to start this patient on a BPAL regime without having any confusion or doubt in my mind. That's something I envision should happen. And what about the unseen fluoroquinolone resistance or the pre-XDR risk? So imagine a 52-year-old male with a past history of self-medication with levofloxacin. It happens a lot. Moxifloxacin, levofloxacin are used right, left, and center in our country. Patients go to a chemist and buy it even without getting a doctor's opinion on it. So this drug is being used. Now, LPA limitation is it misses uncommon non-hotspot GYRB mutations or low-level GYRA resistance variants. This is the problem with LPA. Consequently, the patient would be placed on an fluoroquinolone resistance regime, and 6 months later, you find that the regime failed. Probably because we did not select a good regime. Now, what does targeted NGS offer? A full QRDR, where it's quinolone resistance determining regions, the full genome is sequenced. You're not going to miss out on fluoroquinolone resistance. And it gives you an actionable outcome. Whether it is there, whether it's not there, based on that, you can select a regime very quickly. So, the dilemma that we are often in when we're selecting these regimes, it can become very easy for us clinicians if we get this data well in time. And then, this has also been talked about, the heteroresistance and early treatment failure. So what is heteroresistance? The coexistence of drug-susceptible and drug-resistance populations. Dr. Dheeraj talked about it. You have the same population in the group, and then, because you're giving them certain drugs, one population is growing more, and the other is not growing. And that causes, so probe thresholds. So conventional LPA requires 20 to 30% mutation allele fraction to register a resistant result. Whereas phenotypic DST can miss even selective freshers. It will say it is sensitive. Targeted NGS can sequence and detect minor resistance subclones down to 3 to 5%. So this is also an important endpoint when we are deciding a regime. So this is the diagnostic landscape that we have. We have targeted NGS, we have legacy pathways. So, gene expert, line probe assay, phenotypic DST, I call them the legacy pathways. This is something we already have. Some of them take too long a time for me. I mean, I'm a big fan of phenotypic DST, but for me, the biggest problem with phenotypic DST is the results come after 4 to 8 weeks. Targeted NGS gives me a result within 24 to 48 hours. It tests for many drugs. I don't think phenotypic GST does well for some of the drugs, but targeted NGS, amazing. It gives you a full gene coverage, and will heteroresistance is also picked up better with targeted NGS. So what are the WHO recommendations? It actually recommends, for first-line and core drugs, moderate evidence for isoniazid and pyrazinamide. I think pyrazinamide really outshines because the other tests for pyrazinamide are really horrible. And low evidence for rifampicin, fluoroquinolones, and ethambutol. But again, this is based on limited evidence. Today, after this conclave, if we have this data coming up, this level, I have a gut feeling, is going to actually get better. For second-line drugs also, targeted NGS may be used to detect resistance in an extended panel, high evidence, low evidence for different drugs. But again, I have a feeling the more evidence that we have, this will actually become high evidence for all the drugs if we start, rolling this plan out. So one of the things that has been said is patient, who do we prioritize this test for? And this is something I actually don't agree with. It should be for patients who have treatment failure, agreed. Smear culture, yes. Previous TB culture, yes. Contact with drug-resistant TB, yes. High MDR settings, yes. But, my question is, why not include all? The first 3 cases that I showed you were all who were characterized as drug-sensitive TB. But mind you, in those 3 cases also, I showed you how this treatment, how this algorithm, how this test can actually change their treatment. So why not all? We actually should, if we are rolling it out, we should think of rolling it out for all. So why is it a conditional recommendation? It's actually because of limited evidence. It's because of the variable diagnostic accuracy across the settings. Some evidence needs to come for this. The suboptimal accuracy to certain specific drugs. The limited evidence regarding cost effectiveness, and feasibility. And the bottom message is, it's a promising technology, but more implementation data is needed. Now, this is where I usually conclude my talk, but today I'm really happy. This is where I'm stopping, and the next speaker is going to speak about policy. You will see that policy change, and if we have a pilot program there, we will know what is the evidence on health outcomes. In this policy, we'll get to know, once it gets implemented, we'll know how good a diagnostic test it is. We'll know whether the accuracy is actually that good or that bad, and the cost and cost effectiveness will also be studied. So when I usually give this talk, this is where I end. But thankfully today I'm ending it with a positive note, that we have something that is going to address this and make life of a clinician better, easier, and not that much confusion in my head. So I would love to hear anybody's views on this, and thank you very much for your patient listening.
Thank you, Dr. Rohit, for that wonderful presentations and a very pertinent issue. And it will be idealistic to have it for all from the beginning. And definitely that's a welcome optimism for all of us. But to be realistic, let us see and hope that will come out in the policy discussions and the program for which we have assembled here. And thank you also, you have highlighted, basically you have dissected the role of UDST on individual drug basis, starting from the sensitive and coming to the MDR and pre-XDR and XDR. And it throws light, though these are cases presented individually, but there are n number of such kind of cases which clinicians are actually facing.
I think all of us, must have seen such cases in our practice on a routine basis.
The only thing is that we are not utilizing the genomic testing because of availability or whatever validations and other stuffs. And the other point, like whether we can recommend it for all, probably we need more data in our own populations to begin with, to whom we are giving HRJD because of the R-sensitive pattern in the gene experts. And let's run the NGS and all of them and see how many we think that they are sensitive, but actually turns out to be resistance to either a monodrugs or polydrugs as you presented that there are 11% H monoresistance to begin with in our populations. So similarly, if this NGS throws light that to whom we believe sensitive and prescribe the HRJD followed by the HRE, but many of them are actually to begin with have also associated H, or as you said, the ethambutol or pyrazinamide, then we know actually what is the prevalence of unknown, undetected, the resistance pattern in our populations, and the regimens will vary from the day 1 or the day 2 by the time you get the report. So I hope you have covered a wonderful thing, which is basically most beneficial in the clinical practice point of view. Due to lack of time, we will not take any questions from the audience at this point, but at the conclusion of the sessions, please keep your questions reserved. There are time to discuss post-lunch during the panel discussions or at the end of the last sessions here. We will take all those questions again. Thank you so much.
Thank you.
Madam, you have to say anything?
Thank you so much, sir. Now may I request our chairperson, Professor Dr. Sonu H. Subha ma'am, to felicitate Professor Dr. Sonali Sarkar ma'am. Now may I request our chairperson, Professor Dr. Manoj Kumar Panigrahi sir, to felicitate our speaker, Dr. Rohit Kumar sir. Thank you so much, sir. Now may I request Professor Dr. Sudarshan Potal, sir, Chairman, State Task Force NTEP Odisha, Professor and HOD Department of Respiratory Medicine, Sri Jagannath Medical College, Puri, to felicitate Professor Dr. Sonu H. Subha, ma'am. Thank you so much, sir. Now may I request Dr. Shipshekhar Datta, sir, Professor and HOD, Department of Community Medicine, Tripura Medical College, to felicitate our chairperson, Professor Dr. Manoj Kumar Panigrahi, sir. Thank you so much, sir. Now we will be moving forward to our next session, session 4.
Good afternoon, ladies and gentlemen. It's my pleasure to welcome you all for the session 4 on policy development partner roles. As genomic DST continues to reshape the tuberculosis diagnostics, its successful implementation depends not only on the scientific advances, but also on the supportive policies, sustainable financing, and strong partnerships. So this session will explore all the practical policy approaches, financing pathways, and collaborative modes that can help make genomic testing affordable, equitable, and sustainable. So I would like to invite Professor Dr. Manoranjan Das, Professor and HOD, Pulmonary Medicine, SCB Medical College, Cuttack, and our co-chairperson, Professor Dr. Rashmi Ranjan Das, Professor Pediatrics, AIIMS Bhubaneswar, for the session on policy financing pathways and development partner roles.
A very good morning to everyone. So welcome to the session 4, that is policy, financing, pathways and development partner roles. So I'd like to invite Professor Dr. Baijantimala Misra, HOD Microbiology, AIMS Bhubaneswar, on the stage to deliver the talk on TB drug sensitivity, what more can be done with existing facility.
Welcome, madam.
Thank you, Chairperson, and very good morning to all of you. And thank you, organizer, for giving me this opportunity. And thank you, Dr. Sosh, especially. So my topic is a very basic, I would say. TB, we are talking about universal DST and genome sequencing and all that. What more we can do with the available facility. Now, before I start my talk, I would like to say that this topic doesn't contest at all the utility of the genome sequencing. Number one, there is no doubt about the role of genome sequencing. Number two, there's no brand, I don't belong to any brand, or there's no brand promotion, because many of these will come during my talk. That's why I'm giving this declaration. So, when we talk about the diagnosis of active tuberculosis these days, it doesn't limit to detect of MTB alone. It detects also the detection of drug resistance. Now, there are several tools to diagnose TB, starting from how we see the bug, grow the bug, and multiply the bug by various ways. And I have mentioned which all can be put or subjected for drug sensitivity testing. And what we used, like we know the disadvantage of smear microscopy by its less sensitivity, and the culture for its long turnaround time and requirement of higher biosafety level. So what is most commonly done these days is the NAT testing or nucleic acid amplification testing. Of course, smear and culture again has its own role. We cannot get away with it. That's a separate discussion. As far as MTB is concerned, we all are using nucleic acid amplification testing. Now, in 2010, WHO rolled out this expert MTB reef in pulmonary and extrapulmonary tuberculosis, which became the game changer. What we have, the advantages and disadvantages, and we have come closer, and we can think of the term TB elimination and all this genome sequencing, because this technique has given us the hope. Whatever we have achieved, it has started from this technique. Now, this CBNAT, which all of you know, it detects MTB DNA as well as rifampicin resistance with a very short turnaround time, with 3 to 4 working hours, I would say, with very minimal biosafety requirements and training, which was a dream before that. Because when we talk about drug sensitivity to clinician, it was matter of months. So that became the matter of hours after this. Now, this again has another more important point. It detects rifampicin resistance. Now, this is one of the most important drug, because this drug resistance detection is a surrogate marker for MDR-TB. Because most of the majority of rifampicin resistant isolates are also resistant to isoniazid. So that's why it's a surrogate marker, and so it's definitely implementable and implemented in the program. Now, the excellent, the steps are very simple to perform, and excellent sensitivity, specificity, I'm not going to detail of it, we all are using and we all know it. The analytical sensitivity is like 131 colony forming unit of MTB in spiked sputum. Now, so this gene expert MTB reef assay can diagnose majority of MDR directly from sample in just 2 hours. Now, what we are forgetting is, now this MTB reef we all are using. In 2017, WHO endorsed another improvised version of it, which is called MTB reef Ultra. Now this, if you see, it has improved limit of detection almost 10-fold, 8 to 10-fold, and it is also faster. Now, the table tells you what are the improvisation has been done, the improved chemistry, how it came out with the improved limit of detection and all that. Now this ultra, if we see the sensitivity specificity in overall in smear and culture positive, 88%, 83%, these are just a few examples I would say, and in smear negative culture positive, 63% versus 46%. In EPTB, the difference is much more, 72% versus 51, 83 versus 67, so on and so forth. And if I give you some of the example, this is in tuberculosis lymphadenitis, you can see the sensitivity comparison in FNA and tissue in ultra is 81 and 73, which is in expert MTB reef, it is 71 and 39. If you see in pleurisy cases, again, if you compare with the CRS, it is expert is 22% versus 52% in ultra, and specificity is almost similar. So if we see overall, there are a lot of many comparison of these two tests. If I take the summary of these results, expert ultra shows significantly higher sensitivity with a marginal decrease in specificity, which is it's happens usually with almost all techniques. So that needs to be used, or that needs to be implemented at least in EPTB and paucibacillary cases. And I really don't know, I'm really surprised why it is not rolled out by the program. And if any authority is there, I do not know, I missed the session yesterday. I really would like to know why ultra is not same. In fact, what I know, the cost is even same. I had purchased for one of the project in which Dr. Rashmi was also there. So the cost is same. Why it is not? I understand the other technical complexity is there, the trace call is there, but the moment you will have more sensitive technique, you will also have some other problems. That happens with every technique. But with such a improved sensitivity, we should first detect more. And we have this in our hand, and we are not in the implementing in the program. That needs to be done. It's high time it should. It has been rolled out in many countries. It's not yet in India. It should be done. Then next is what the NAT, what we all are doing is Gene Expert and TrueNAT. We all are aware of this. Now, TrueNAT, CBNAT I have already mentioned. TrueNAT is a multiple step procedure, and it's an excellent test. It's endorsed by WHO for this pulmonary TB. And if you see the sensitivity and specificity, it's quite comparable with expert MTB reef. There is no doubt in that, but there is a small glitch. Now, this is, of course, like what I wanted to show over the years when we started CBNAT. Look at the sample number, how it is. It's almost touching 10,000, more than 9,000 a year. And in this, I would say, when in the initial period, the program used to supply CBNAT only. And here, what I would like to highlight is, we do not have a head-on comparison. In fact, we cannot, because the program supplies and we have to do one test. We cannot do any study, and I don't think if I apply for any project, no one is going to approve this type of project. There's enough evidence is there. Now here, what I would like to highlight, if you see the upper graph about CBNAT, when you were using CBNAT, about the sputum sample, the positive, the orange color one, and the indeterminate, rifampicin indeterminate, the gray one, hardly you can see the gray color. Am I right? Now, even if the positive number is, 199, 138, whatever, the gray is in single or maybe just above 10, 11 like that, or even mostly in single digit. Whereas the lower graph on TrueNat, which we are using because that is what is mostly supplied by program, the gray color is quite visible, even if the number of positive is in the same. It's not a systematically conducted study, it is just observation of the lab result. The orange, you can see 150, 144, whereas quite visible, the gray bar is 58, 39. So what we are giving to the clinicians? Indeterminate RIF. So, which can be solved. Now, this is the algorithm. It's quite busy slide, I can understand. This is the algorithm by this booklet by WHO and this top TB partnership, which gives the TrueNat TB test as the initial diagnostic test for pulmonary TB. Now you can see the right side, I don't know whether it is visible or not, the indeterminate or error, the rightmost red color one, where it says that if that happens, repeat TrueNat MTB RIF diagnostic test, follow this algorithm to interpret. If both tests give indeterminate, then treat with first line regimen, promptly conduct additional investigation to assess RIF resistance. Now, again, this booklet says that further investigation for TB may include chest X-ray, additional clinical assessment, clinical response following treatment with broad-based antimicrobial agents, and repeat TrueNat TB testing, 10 testing with other WHO-approved rapid diagnostic, for example, expert MTB, RIF, ultra, or culture. So, at least in indeterminate cases, the program should allow us to do this MTB RIF, or at ultra is not yet rolled out. That also is, I think that should be there in the program. And this, to solve this indeterminate, again, what we have in our hand and we are not able to utilize is this expert MTB RIF ultra. Now, third, detection of XDR, or this fluoroquinolone and cycloline injectable drugs. What do we have? I'm talking besides the genome sequencing. Now, we have line probe assay, which detects rifampicin, INH, and these fluoroquinolones, levo and moxi, and aminoglycosides like amikacana and capromycin. Now, this is about another improvisation of expert RIF. This is expert MTB XDR. Now this, again, the left side tells you what all drug resistant it detects: isoniazid, fluoroquinolone, and other this amikacin, kanamycin, and all. And if we, this gives a comparison with the phenotypic DST versus sequencing. If we say sequencing as the gold standard, look at the sensitivity of and specificity of XDR. It's almost reaching 100% in specificity and 95% or more in sensitivity. And this is another study about GeneXpert MTB XDR, which detects INH resistance. In CBNAT, we are detecting RIF resistance. As we go closer and closer to elimination, we are talking now a stage genome sequencing. At least we should detect INH in all cases, and we have it with us. So this XDR can do it. Of course, other WHO tests are also there, but they are mostly high throughput. So it can detect INH resistance. So in true sense, we can detect the true MDR cases. We will not miss any true MDR cases. It detects resistance to fluoroquinolone. Dr. Rohit mentioned how fluoroquinolone is important for clinicians. So pre-XDR cases can be detected, and it also detects injectable second line drugs. So again, we have it. Of course, it needs a higher version of the instrument, that is the 10 color model of this. And this instrument also is there in many of the institutes. In fact, in our institute, it's also with us. But at the same time, like the consumables are expensive, and you can't ask, the TB patients, who are mostly poor patients, to ask for 2,000 to pay for XDR, and that should be, and why it should not be there from the program. And if you see the complexity, this is the complexity given by WHO, comparing the CBNAT, this expert and LPA. Expert comes in the low complexity. That means it can be done in a very remote area also. Whereas line probe assay, also we do, and it really requires, it's technically demanding besides other limitations. So what I want to again highlight is the need for expert XDR to detect drug resistance to other antitubercular drug other than rifampicin, like INH and fluoroquinolones. So I'll summarize my talk here. We should detect more TB cases, number one. To provide more precise rifampicin resistance, not more of indeterminate and giving an inconclusive result to the clinicians. We are not then fulfilling our role as a microbiologist. To detect drug resistance to more antitubercular drugs besides rifampicin. So implementation of expert MTB-RIF Ultra and expert XDR should be there before we, of course, as I said in the beginning, there's no contest of the role or utility of genome sequencing, but these things, we have it in our hand, and it should be implemented. It is high time we should implement it in the program, and it should be used more and more. Thank you.
Thank you, Madam, for your wonderful talk. For the positive time, we can invite one or two queries. If any audience having any queries, please, it can be clarified in this forum. Madam is the expert on that part, ma'am. Ma'am, if there is no question, I am having, actually nowadays, madam, we are facing many TrueNet positive. If we repeat in the line of resistance and we get the CBNAT empty is not detected.
Yes.
If that is the main issues now, madam. Actually,
yes, that can happen. That usually happen with the low bacillary load. In TrueNat, if you see the manufacturer's instruction, the sensitivity bacterial load wise is high, it can detect lower bacillary load as compared to CBNAT. But it also gives a rider that the bacillary load, as it becomes lower and lower, the positive predictive value becomes less and less, which is expected.
And should we treat those?
Repeat is a problem in a lower if the bacillary load is less. Are you getting the bacillary load also in your result?
Yeah.
Yeah.
That we're getting.
So the moment it is what we have observed, the moment it is less than 10 to the power 2 CFU per ml, then your result is plus minus. It gives positive, but if you repeat with CBNAT, it gives negative. So then again, we are creating confusion. So whether you will give a benefit of doubt or you will refrain yourself to treat the patient. So that's a big query. But if you go practically, if the technique has the power to pick up more, but at the same time, we should also understand the technical complexity of it. In the wherever the bacillary load is less, the next sample may not be having the same bacillary load. it might be having the less bacillary load or maybe nil. So it may not be picked up even by TrueNAT. So repeat, we have done a lot of repetition in the beginning
Yeah.
when I didn't have experience. Then I found that it actually doesn't giving me any solution.
Actually, you are absolutely right, madam. That confusion still is with us
Yes.
because symptomatic patient, radiologically normal, the TrueNAT detects the MTB detected, reef is indeterminate, and sputum CBNAT it is MTB not detected. That is the real confusing point for the
Yes.
physician, but to treat the patient or not to treat the. Thank you, madam. I think we will move to the next session.
Yes. Thank you.
So next talk will be delivered by Dr. Siddharth Giri, scientist RMRC Bhubaneswar, on policy and financing pathways for genomic testing for MDR TB. It will be online lecture, I think. Online. Yeah.
Please wait, we are connecting to him on a video call. So.
Hello, Dr. Giri, is it audible? I think you should unmute yourself, Dr. Giri.
Kindly have patience. We are trying to connect with our speaker. Till then, if anyone has any question to ask.
Sorin sir, can we move to the next speaker at the last session? We will keep this. I have a talk. I think that will be better. Ma'am? Okay, okay.
Hello.
Dr. Siddharth, good to see you.
Yeah.
Are you ready? You can
Nice
start
to
your
see
talk.
you.
Yeah.
Yeah. Sorry for the delay in connecting. So,
You can share your screen. We are able to see you and you are audible also.
yeah. Is it visible now?
No, it's not visible.
I have shared the source already.
You
Are
can
the slides visible?
share your screen.
I have done that.
I
You
think
can stop share and redo the sharing.
stop share. Yes. But your connectivity is poor because the red signal is coming. So that may be the reason.
Okay, if you are having slides, you can share with us so that we can display in our screen. Should we share, Dr. Giri? Should we share in the screen?
Yeah.
Okay, we are
Yes,
sharing.
yes.
We are
Can do
sharing.
that.
You just stop sharing. We are sharing and you just have a talk. Just a minute, Dr. Giri. It's
Yes, sure.
yeah. Now it's displayed in our screen. Dr. Giri, we can move ahead.
Yeah. But I'm not able to see the slides. Uh,
Yes.
Shall I share once again?
Yeah. You try again, please.
You can switch off your video because sometimes the video causes problem in the bandwidth and you can share. Okay.
Yes, exactly. Yeah. Is it visible now?
No, it's not visible. You double click that entire full screen mode.
Yeah, I've done that. It's in now. Other, give me 2 minutes, I'll rejoin. Just give me 1 minute. Just please, sorry for that.
I think, Dr. Giri, you change your location where the network connection is better. In the meantime, we will go for the other speaker. After that, you will join, sir. Okay. Yeah, yeah. I think because of some signal issues, so we will move to the next speaker. In the meantime, I hope the technical team will rectify these issues. For the next speaker, I invite Sri Nandis RP and Srimati Archana Bias, Indian Country Director. They will deliver a talk on the role of development partners. Invite you, Dr. Sri Nandis. Second speaker, Srimati Archana Bias. Over to you, sir.
Thank you, sir. Yeah. Thank you. A very warm good afternoon to everyone. I am Nandish, Director, Policy Resilience Foundation, and I'm very thankful to all of you to be part of this wonderful policy conclave. Thank you for the session chair also to join us. Today, by the blessings of Lord Jagannath, we'll begin little bit of policy discussion. Now, very interestingly, the subject is role of development partner and philanthropic ecosystem in scaling genomic testing for MDR-TB. I would start with this disclaimers that I am not commenting on any of the existing policies, whether they are good, bad. Neither I am authorized to say that we should do this. I'm the least experienced maybe among all the delegates here. But what is policy? What do we mean by policy? The moment you sit here and Google policy meaning, you'll get something very interesting. So I've defined little bit in a quicker way that what do we mean by policy? A policy is always a plan and action. You see, when you Google it, you'll actually come to know that if we speak policy, there has to be clarity on the action. Now, many of the translational research which keeps happening needs the clarity on action. How do we do that clarity? How do we get that clarity? Probably we'll have a little discussion and a lot more other discussions that happened in past. A policy from my lens stays, it's a data-driven action plan and the way of acting or making efforts that you think is best in that particular situation. So, can any situation stay constant? Maybe no, because only constant is change. So policy is also ever evolving. It's not constant at one pace. You've seen this map a lot, and I think I would be third or fourth speaker to show this map because this is part of Global TB Report 2025 published by WHO. But here I'm introducing a different lens to see. Can you see the big red dot over our country, Bharat? And then you see the number that it's 32% of the global cases which are accounted, which have developed MDR and RRTB in incident cases in 2024. Now you see our neighbor, I would not name them, but there are a lot of neighbors here. And one of the important neighbor that we keep discussing a lot has 7.1%. So clinicians, we are thinking, okay, let's do something. Scientists, genomic sequencing people, they think, okay, let's do more and more genome sequencing. I am putting a lens of biosecurity and biothreat. If you see this from a lens of biosecurity and biothreat, now this 32% number is concerning us as a country. Why it is 7.1 in China and why it is 32% here, maybe something is going on from a global security standpoint. So can we see from the lens of biosecurity with a strategic imperative, a national framework, whether it's policy, technology, protocols, to prevent, detect and respond to the biological risk of communicable disease. Let me go a little bit more above the clouds and tell how the communicable disease lens would look like if you compare it with the COVID-19. Whether it's natural, whether it's accidental or deliberate. Biological threats could actually destabilize the economies, public health systems, national security, and they are much faster than the conventional warfare system we all know. Is there any discussion needed for policy and governance which can give us enforceable biosafety and biosecurity standards across the sectors. Can we see our problem from this lens as well? Probably yes. How do we see it? We are already doing surveillance, integrated disease intelligence and early warning systems. We are already prepared like we got prepared in the COVID. If you see the communicable disease outbreak response, our country was really well considered, even at the World Health Assembly level. WHO also appreciated the way we responded. So our resilience is now already developed. We have a capacity. We have precedence of how to handle the communicable disease, whether it is investment, whether it is R&D, whether it is health infrastructure or public trust and confidence. So now we see another map from Global TB Report 2025 by WHO. Now these green colors would mean a very little thing but very important. The lightest green shows the country who only do survey. They don't do surveillance. They just do survey. The dark green shows survey and surveillance. So which is very important. They do survey, they do surveillance. And then there is darkest one which shows they do surveillance completely. So you see our geography and our neighbors fall in same category. We do survey and surveillance. And anti-TB drug resistance, this data tells us a lot of things about biosecurity and biothreats. There are two main sources of data about the level of anti-TB drug resistance: National Survey and Continuous Surveillance, that is routine diagnostic testing for drug resistance among people diagnosed with bacteriologically confirmed TB. By the end of 2024, 89 countries and areas have represented the data about level of resistance to rifampicin from continuous surveillance system. 21 had nationally representative survey data dating from 2000 or later, and had 66 countries had the data from both continuous survey and surveillance. This was shown in last figure, that is 1.3. I have copied exactly what is written in WHO without deviating. So this total of 176 countries and areas worldwide collectively are accounted for very interesting number, 99% of the world's population and 99% of the incidence case of TB. So that's the concern for our country. That's where we need to come together. I'm no other guy who would work in the silos, but probably you try to create a natural cohort of people who will come together, discuss, deliberate, and come to some action plan. So 43 countries that are one or both listed in high TB burden, high MDR RR-TB burden countries have been used by WHO in period of 2021-25. 41 had survey or surveillance data on the level of drug resistance, only 41. So what is a biothreat? Why I'm saying repeatedly this? The emerging frontline warfare it's very cheap. It is the cheapest form of warfare. It is low cost, high impact, asymmetric weapon, accessible through dual use biotechnology and global supply chains. If you Google these 3 keywords, covert bioweapon program, you'll be amazed to see how world is progressing. You'll be surprised that how many countries are continuously funding these bioweapons. Put a more stronger lens of bioterrorism and cyber-enabled biosabotage. These words looks fancy, but I really recommend you to once just Google it. And I think the AI mode of Google will trigger in and it'll throw you the load of information. So whether these are all accidental lab or synthetic biology misuse, what are the national security implications with this? The collapses of public confidence and social order, strain healthcare and logistic networks, requires cross-domain coordination with the defense and health intelligence. These are a little bit of national security implication without any disclaimer. I'm putting it in the open forum. And what should be the policy response? Strengthen, build regional response network, promote transparent scientific governance, and dual use of the oversight. So what is the need and focus? I'm coming back to the TB. Our India's commitment to eliminate TB by 2030 hinges on the acceleration of detection and early intervention, especially for multi-drug resistant TB. And shift from phenotypic to genotypic, that's genomic, probably is the need of time. We can have a lot of argument, we can have a lot of discussions. Clinicians are there to discuss and debate. But if this knowledge and database is created at the institutional level, we exactly know where do we stand, where do we have to go, and how to cover the gap. That's what we can do in the challenging region of Eastern Bharat, sitting here at AIIMS Bhubaneswar. So we all know COVID time, test, treat, track. The fight against TB must move on testing alone, on continuous loop of test, treat, track, ensuring. These are all clinical terminologies. I'm just copying it from somewhere and putting, but why I'm putting is very important. Every sample, every patient, every case probably will give us a next step to fight. Probably this is what I've learned from the clinicians. The way we document it, the way we understand it, and the way we come to a conclusion. It's not replacement of any test. There is no such word called replacement. There is no such word called obsolete technology. Let's put everything into the basket, choose whatever is needed. So the approach from the policy lens in a larger context could be a one genomic approach for all XDR-TB. What genomic does, what genomic does not do, we had really good amount of discussion, but I am interested as a policy maker from PRF, non-government organization, is to see the data, to have a data repository. The moment data is there, right from a patient level till the tertiary care level and till the program level, you put it in one lens, slice it down depending on the threats. You will be amazed to see that there are multiple ways that we can approach this. So coming to my exact point of how do we finance the pilot. So anything, if I need data, we need to do some pilot. Today it is genome sequencing, today it is NGS, tomorrow there is something new coming up. How do we do it? What do we do? Do we straight away do some protest and say, oh, include this in policy? No, that doesn't work, because policy is not protest. Policy, you need a lot of data. You need a strategy to do a hybrid financing for that, and a strategy in which there is involvement of CSR funds, philanthropic funds, public support systems, academics, startups, everyone put together builds an ecosystem to do those data collection and do the pilot program. So here a small table to build a samanvay, we call it coordination, between all the stakeholders. How do we do? Mostly if you see the CSR activities, they do fund capex. They are very keen to do the capital expenditure. So if you want to do labs, whatever equipments for hub and spoke, who are these CSR entities? They are PSU and philanthropic research funds. Nowadays, beyond CSR, there is ANRF also dedicated, but that's a separate story altogether. CSR funds are much easy to accessible, which is not government. Also, non-government CSR fund, I would be very specific. Philanthropic funds like our organization PRF, Gates Foundation, Infosys Foundation, multiple of those institutions which are ready to fund on digital health. We are ready to fund on the digital tools, which are complementary to Nikshay, which are complementary to the existing tools and dashboards of the state and the district level. We are ready to fund that. You give us a design, give us a design problem. We have people who will sit and develop the tool dedicated for you to collect the data, analyze the data, and come to some conclusion. Then what will be the public support system? So there is a lot of integration of the existing programs. For example, today when we had a question of how can NII collaborate with AIIMS Bhubaneswar, not necessarily the collaboration will require funding first. It can be over a period of time, there can be a point where we can seek the funding. So the integration with ICMR, DBT, NHM, AIIMS network, and who are the key contributors for that? Ministry, DBT, ICMR, all the state health department, AIIMS and state medical college can come and get the interdepartmental collaboration which will break the silos, start the information, collecting the information, sharing the information to the authorized researchers. Then the academic startups and partnership come. Now this is the most vital point today I want to emphasize. Why? I saw Dr. Rohit very clearly mentioning which are the tests, which are the companies. Even Dr. Sonali also said some GenoScreen from France, Oxford Nanopore from UK. There is one more company from our friendly friend, Border. I would not take the name. But there is no Indian startup. There is not a single entity which has come up and said, okay, we can develop a kit. Here is an opportunity. AIMS can collaborate with us. NII can collaborate with us. ICGB can collaborate with us. We can put a proposal. Can we do this? Now we just go a little bit backward period during COVID time, and we had multiple people coming to us because it was life and death, because it was no go situation. There is no way forward. Let's come and do something. So similarly, academics and startup partnership is the breakthrough from the policy lens. This breakthrough needs, for example, AIMS Bhubaneswar is coming up with a testing kit in the eastern region. We need a pilot. We need to go to district level, do some data collection, compare the testing results with the gold standard test, say whether yes, you are failing or succeeding. You might fail. There is a chance of failure, and institution will give the immunity to fail. But then it's a lot of learning that what can be the next step to achieve the success. So academic startup partnership is also the most important. So here, when we are partnering with AIMS, we are essentially open for the collaboration on digital side, and also to create the ecosystem of academics and partnerships with the startup to ensure that we go lead into the breakthrough of the technologies. Now, what are the pilot project if we want to do in the state of Odisha? How do we do? What do we do? We've done a little bit of discussion almost of similar nature in the Assam, and we have already progressed ahead with the pilot project. So we identify these spokes as peripheral health centers. The option is whether you collect the sample by road, or there is also a push on deploying the drones from the AIM, which becomes a pilot project as well. Send them to the remote locations. These are not new things in our country now. We know how drone operates in the AIMS. There could be one or two failure reasons, but that doesn't stop us. We're still moving ahead as a country, and we are progressing. We can have on-site mobile labs or on-site testing setup. Hub could be the AIMS Bhubaneswar or RMRC NRL lab. And mobile labs can carry full set of equipment which needs to collect the sample, process it, store it, and bring it to the hub. Or the sequencers could be sent to those districts which are being heavy high burden to avoid the logistic issues. So digital connectivity to Nikshay platform, ensuring the real-time data reporting. These all things is possible if we sit together and think and plan to do an action as a pilot project. A unique digital tool that we can think about, I'm proposing on this forum, is Odisha Nikshay Stam. Now Nikshay is already there. Nikshay platform is one of the most robust platform. It has done fantastic. We have got so many Nikshay Mitras, more than 2 lakh My Bharat volunteers, over 6 lakhs of Nikshay Mitras registered there. What could be a supporting pillar from the state to the Nikshay platform? A thought process has happened, and we can come up with one of the pillar called Odisha Nikshay Stam for the pilot efforts. We just document the pilot in the system connected to Nikshay so that other researchers, other authorized people can also see what's happening, how it is happening, whether it is going in right direction. So it brings transparency and traceability. And probably our proposal is to implement the East Region Genomic TB pilot project covering minimum 2 districts. Each district will have a coordinated network of mobile or on-campus labs as fixed hubs. PRF can help co-creating the Odisha Nikshay Stam, a digital tool to bring transparent, traceable digital monitoring systems, clinical validations and data audits, policy feedback mechanisms to CTD and MOHFW. This is purely to strengthen the existing system, not at all contesting or replacing anything. What are the monitoring and validations? So all activities which are recorded in the pilot has to be given to the decision makers real-time dashboard, third-party audits, and integration with the Nikshay. Now, what could be the governance at state level? So the governance could be the steering committee which can be formed at the government Department of Health at Government of Odisha. Who could be the possible committee members are AIMS Bhubaneswar and subject experts, STF, State Task Force and Government of Odisha, development partners, and the special invitees like Dr. Digambar Behraji, who has extensive experience on how to run the programs and the pilot projects. So PRF can again co-create the fund to set up a policy research unit, to collaborate for the pilot efforts, to digitally and on-site documenting the data with the targeted impact of drastic reduction in the diagnostic turnaround time, huge drop in TB-related mortalities. These are the few targets with which we will begin. The target which we are mentioning on the top are what our aspiring targets are. But the important data repository that we will end up creating, we are not saying that, okay, genomics is only the best way to handle the problem. No. But by doing genomics, are you able to create India's first TB resistance atlas for the state of Odisha? If that's possible, I think it's worth giving a try to do a pilot project. A model framework and recommendations could be derived out of it for the national policy on TB genomic testing. So now the time is for the action. Time is now to fund the innovation, not as a charity. It's a national investment in health resilience. Most of the funding, they think, okay, charity में थोड़ा सा donation दे दिया हो गया, वो लोग जो भी होगा करेंगे. No. Let's correct ourselves. We have corrected ourselves first, and we see our contribution, our grants as the national investment in health resilience. PRF stand here to lead, co-create and implement the digital spine of policy innovations, ensuring transparent, validated and policy aligned outcomes. स्वस्थ नागरिक ही स्वस्थ राष्ट्र का निर्माण कर सकता है. टीबी हारेगा, देश जीतेगा. Policy should stay ahead of innovations is what we believe. Thank you. Namaste.
Thank you, Mr. Nandis, for an wonderful talk, and you are really doing a great job actually in collaborating with the government and private institutes. Wonderful job actually. So is there any question from the audience? If there is 1-2 question we can take. Ask regarding the innovations or any kind of research question in mind or want to collaborate, something like that. That can contribute to the policy.
Mr. Nandis, one thing. Is the drone policies has been applied in any state of India or any place in India?
Sir, this is more prevalent in the northeastern region.
Yeah.
For example, AIMS Guwahati. And I forgot, I think it's also in Meghalaya. In the state of Meghalaya, they are doing by themselves. The reason is because they have to climb vertically up, and it takes too much time to do the hairpins. So they are the people who had real problems. They've done it, they've failed multiple times because of weather, their drone crashes, but they've learned a lot. And our DGCA, Director General of Civil Aviation, is promoting this transfer of the samples, blood samples, medicine by drone. They're promoting like anything. So precedence is there with AIMS Rishikesh, AIMS Guwahati both.
I think near future it will be more successful program.
Yes.
Thank you.
Sir.
Yeah, please.
Mike.
Give a mic to Chris.
Hello. So myself, I'm Dr. Parish Manthi. I'm the in charge of Intermediate Reference Lab in SCV Medical College, Cuttack. So this is my 16 years of experience in the field. I am doing continuously on drug resistant tuberculosis. So how the state, how the country has come from your culture lab, conventional, to this genomic, genetic early diagnosis. So my question is just now, since you have asked some policy or innovations, so my concern only is now in the field is that, so sample transportations, actually what is happening, so the sample which are collected at the peripheral level and reaching to the referral lab, so it is, we are unable to track the exactly the when it was collected, when it they have packed and they have sent to the lab, and what is the transition time and reaching at the lab. So this figure actually is not a real time. We are not able to track it. Though there was a discussion in the Central TV division that they will develop some your like to how to track in Nikhya. So they have some discussion, but it is not yet we have able to implement in the field. So my question is that if the sample is not coming timely, so it is not. It is very difficult because you know the samples which are bacteria which are there, that because we are not putting any or transporting media. So those samples which are coming, they will very soon disintegrate, or the bacterial cells will be disintegrated. So that is how to develop this system, digital, since you are very concerned about the digital, your technology and all you want to implement in this system. So my question is that if you can develop it like this, so how it will be easier for us to track exactly what is the time. So by that you can request the people that repeat the sample, or we can hash in the laboratory people that we should perform like this. So this is actually the field problem which I am saying. So research is different things for me, but for me there's a practically, because negative, when you are saying negative, neither culture is positive, neither NAT is, so the clinician are very confused. And besides that, I think the other people they may discuss. So this now the genetically diagnosis is making very confusions to everybody, because true NAT में आ रहा है, CBNAT में नहीं आ रहा है, इसमें आ रहा है, उसमें नहीं आ रहा है. So that was a discussion by NIRT Chennai also, that madam, I am just forgetting her name. So they have told the last thing is that either your gene sequencing, or best is your conventional culture to settle down the disparity. So these two things I request to you. So how to implement these two things correctly, so that the clinician will have the best things and patient will get the best treatment. Thank you.
Thank you. Thank you very much. So I understood your two questions. One is the logistic problem of the sample, and second is the gene sequencing made both sara confusion. So second one maybe clinically I will not touch, but non-clinical I will discuss. But first one, I'll tell you a precedence of this. All our vaccines during COVID and our Government of India's mission Indradhanush is transported in a box which maintains and shows the temperature and its position through a little small GPS thing which gets charged. And nowadays this cost of this GPS is peanuts. So you get those Apple AirTags, if you know, people, they put it in the bag of the children, so they come to know where is my son or daughter going. So we can solve this technology problem very easily at a very low cost, and probably a collaboration with the nearest IIT Bhubaneswar and AIMS Bhubaneswar can take up as a challenge, form a project and do some smaller off-the-shelf product integration. It's not a big thing at all. I can guarantee that it is solvable. And I can tell you another precedence of all of these smaller tagging of the samples. These are done already in a lot of private labs, because the purpose of testing is very different from them. So technology is available. It's just that if we can integrate it in our pilot project that we are proposing, it will be really outcome we can publish also and we can share. Second,
Barcoding system.
Not just barcoding, you need a GPS tag, and
Okay.
you need something else, one more sensor to ensure that you know the exact position.
Yes.
Where it is, right?
The GPS is very important, because not barcoding, because people can put later on that barcode.
Barcoding, it's
So-
as good as a courier service.
Yeah.
So you don't know where it is stuck.
So exactly that is the it.
Sir, I think the speaker is next speaker is on the line. Thank you, Mr. Nandis. Thank you,
very
Paresh sir,
much.
for your wonderful
Thank you
discussion.
very much.
Thank you.
Thank you, sir.
Yeah, good afternoon, everybody. Are the slides visible now?
Yeah, slides are visible and you are audible also.
Thank you so much. So, good afternoon to everyone. And at the outset, I would like to thank the Policy Resilience Foundation and AIMS Bhubaneswar for inviting me for this talk. I think during the last 1.5 days, a lot of what I'm going to present might have already been covered. So I'll try to keep it short, and I'll focus on the policy and financing pathways. But because it's about MDR-TB, a little bit about MDR-TB before we go on to the other aspect. So this is the India TB report 2024, and there were close to 64,000 MDR RR-TB, of which 11,800 were PXDR and 114 were XDR-TB, and about 92% were initiated on the second line treatment regimen. The way forward suggested by the National TB Elimination Program is to increase the use of chest X-ray, to improve efficiency of screening, improve microbiological confirmation, scale up NAT, improve UDST coverage, and to complete the algorithm of diagnostic tests for tuberculosis. So when we move to the global scenario, it still is a big threat, and in 2023 around 400,000 cases were there. So if you look at the new cases and
Sir, sorry to interrupt, Dr. Gary. Your slides are not moving.
Not moving?
No. It is only the front slide it is showing.
Okay. Now can you see the slides?
So only the front slide is visible. First slide.
Now also?
Yes, sir.
Okay, now?
No, now it's seen. Now it's seen. Thank you.
Now?
Yeah.
Okay.
Like this you keep.
Okay, I'll keep it this way.
Exactly.
So
That will be better.
Yeah. So I was talking about the India, the burden of drug-resistant tuberculosis in India, and this is the global scenario from the World TB report, where 400,000 cases of RR-TB were reported in 2023. Can you see the next slide now?
It's seen. You please carry on.
Okay. Thank you. So if you look at the proportion of new, MDR in new and previously treated cases, you see that 3.2% of new cases and 16% of previously treated cases were MDR or rifampicin resistant TB globally. And if you look at the whole burden, which I'm sure the previous presenters have shown. So you have 5 countries are responsible for the major burden of multi-drug resistant or rifampicin resistant TB, of which India contributes to around 27%, followed by the Russian Federation, Indonesia, China, and the Philippines. So with this scenario in mind, we know how important it is to, to have an entire gamut of tests for genomic surveillance for MDR-TB. So we all know that whole genome sequencing holds immense promise for understanding the transmission dynamics and the drug resistance pattern. And the COVID-19 pandemic has led to an unprecedented expansion of the genomic capacity in many low and middle income countries, including India. And it is now time to use these very facilities for performing genomic surveillance for MDR-TB. And the integration of machine learning with genomic and clinical data offers a very powerful avenue for prediction of drug resistance in India. So in the recent years, genomic tools have shown great promise in the fight against TB. They have been, although not in a surveillance mode, but in project mode, it has proved to be an important tool in the rapid and accurate detection of TB, identification of drug-resistant mutations, and providing critical insights into the transmission dynamics, outbreak origins, and looking at the evolutionary patterns. So this slide just shows how, although we say NGS is a useful platform, but it needs a lot of skill sets to establish these laboratories in a surveillance mode across the country. So you can see that, you from sample collection to DNA extraction to library preparation, followed by sequencing, and then most important, the bioinformatics capacity to analyze those data and report the results within a short time. So coming to the conceptual framework, linking three foundational pillars. So I'm going to talk a little about technology, policy, and equity here that underpin effective TB genomic surveillance and control. So when you say the technology component, we are talking about the sequencing platforms, the analytical tools, the data systems which need to be in place. Policy refers to governance frameworks and sustainable financing and integration into the national TB programs. And equity emphasizes on capacity building, access, and to develop trust to ensure inclusive benefits across regions. So these three are quite essential if you want to have a successful genomic surveillance system for tuberculosis in any country. There are several challenges that hinder the effective use of the infrastructure for genomic surveillance in LMICs, many of which we are already aware of. It includes unstable funding, high reagent and equipment costs, insufficient training in bioinformatics, significant delays between sample collection, genomic sequencing, the reporting of data to the public health authorities, and submission of this data in the national and global databases. Over-dependence on supply systems based in high-income countries. So there are procurement difficulties and data management issues. Then, of course, all of us from the lab side will be aware of the equipment maintenance issues, the reliance on proprietary softwares, and the lack of external quality assessment programs for genomic surveillance. And of course, the costs of doing NGS and resource constraints settings are significantly higher. Sometimes it may be up to 10 times higher. So coming to the strategies now, after the challenges for effective genomic surveillance for NDR-TB, the first and foremost is strengthening the existing surveillance systems and then integration of genomic surveillance. As it was being discussed that there are issues with sample collection, sample transport. So all those need to be addressed also. Then the second issue is capacity building and training of human resources. As I have already mentioned that genomic surveillance will be quite, a lot of investment will go into the training of the staff who will be involved in this. And then, of course, the third one is the data sharing and collaboration in real time. So coming to the first one, strengthening existing surveillance and integration of genomic surveillance. So the integration of genomic surveillance into existing infectious disease surveillance is necessary. And there is a need to assess the capacity for pathogen genomics within existing surveillance and laboratory systems at the regional and country levels. The third thing is we need bioinformatics expertise, data analysis capabilities, and mechanisms to ensure quality, such as to have external quality assessment programs. So all these can be implemented successfully if the national government collaborate with international organizations, academia, private sector, NGOs, and regional networks to integrate sequencing into the public health system, because it needs a lot of investment in terms of finance, human resource, and other issues. This I have already covered. Capacity building and training of human resources, how important it is to understand the whole pipeline of doing next generation sequencing, and then understanding the bioinformatic pipeline to analyze the data which you have created using NGS. Now coming to the financing models and sustainability. So there we have seen sustainable integration of WGS into TB programs in some countries, but this requires not only technological readiness, but also robust financing networks. And in most low and middle income countries, the high initial capital costs for sequencing platforms combined with recurrent expenditures for reagents, maintenance, and bioinformatics support necessitate that we have diversified funding strategies. And one of the most important is the public-private partnerships, which have shown promise in bridging these gaps. For example, either through cost-sharing agreements with the diagnostic companies, philanthropic support for reagent subsidies, or to have collaborations with the cloud service providers to reduce computational infrastructure costs. Then national budgeting strategies are needed to integrate sequencing with broader TB control program funding streams, and to make sure that genomic surveillance is not treated as a standalone research activity, which is currently mostly happening, but as a core public health function, which becomes an integral part of the national TB elimination program. So there can be innovative approaches such as pooled procurement of reagents and consumables at regional and national levels, which can reduce costs. Long-term sustainability will also depend on having a blended model, combining domestic financing to have donor support, a public-private partnership-driven innovation, which is embedded within the national TB control budgets. Without these efforts in place, whole genome sequencing, it might be implemented in certain pockets of the country, but it will remain a pilot level innovation rather than becoming a routine tool in high burden settings like India. So these are some of the examples I will give which has happened globally and how some of them have been driven by public-private partnerships. So we are all aware of the WHO catalog of mutations, which was first published by WHO in 2021, and in 2023 they came up with an analysis of over 52,000 isolates. So similar to this effort, in India we created the India Mutation Catalog. So in 2022, following the WHO Mutation Catalog, the India Mutation Catalog was introduced, which was an India-specific catalog from data from 25 states and four union territories, and it included close to 3,000 isolates. So now the version 2 is also available. This current version comprises close to 9,000 isolates, of which 27% were drug-sensitive isolates. And the most important part is that this whole effort, which along with the National TB Elimination Program, it was founded by the Gates Foundation and the Wellcome Trust UK, which again shows the importance of public-private partnership, international funding, academia, in having this kind of an approach to be embedded within the routine National TB Elimination Program. So this slide actually shows a study which was done. There have been recent economic evaluations which provide encouraging evidence that routine sequencing can be both feasible as well as cost effective in LMIC settings. So this study from India, South Africa and Georgia reported that targeted NGS was cost saving and health improving in India, cost effective in South Africa, although they could not find favorable results in Georgia. However, the overall scenario analysis showed that reducing per test cost by 50% rendered targeted next generation sequencing as a cost-effective option across all three countries, underscoring the importance of scale-up, batching efficiencies, and using multi-pathogen sequencing applications which can improve value for money. This is a study, another study from India, which shows that pilot programs integrating whole genome sequencing into the national TB control demonstrated feasibility. But also this study underscored persistent barriers related to reagent costs, centralized infrastructure, limited capacity for large-scale data analysis, which I've already mentioned. So with those studies in mind, the last few slides will focus on what India has been doing other than the mutation catalog, which I've already discussed. So we are all aware of the data-driven research to eradicate TB or dare to eradicate TB as part of the India Tuberculosis Genomic Surveillance Consortium, which was launched on the World TB Day in 2022 and spearheaded by the Department of Biotechnology, the Council of Scientific and Industrial Research, and the Indian Council of Medical Research in collaboration with major clinical institutions. So this again emphasizes the fact that we are not talking just about public-private partnership. Within the government of India also there needs to be extensive partnership among the different organizations if we want to have such genomic surveillance in place throughout the country. So these are some of the objectives of those studies, which I'll just go through quickly to perform whole genome sequencing for more than 32,000 isolates, to map the genetic diversity of pulmonary and extrapulmonary TB, to look at the associations of mutations of MTB to drug resistance patterns of human host, and to combine epidemiological data with WGS results to extract actionable public health data driven information. And this shows the first announcement of the completion of 10,000 genome sequences, which was done by the Minister of Science and Technology. So next, I would like to say that nowadays the government of the organizations under the government of India is coming up with huge grants also. Everybody is aware of ICMR grants. So the small grants, the intermediate grants, the Center for Advanced Research. In fact, Center for Advanced Research is a huge funding by the government of India, which is done by ICMR, which can be funded up to 15 crores. These are again two, I have shown two calls. The recent one by the Indian Council of Medical Research, which shows expression of interest for development and validation of diagnostics. And the other is an older call by the biotechnology, the BIRAC, which called for enhanced TB diagnostics and adjunct technologies for sample collection and processing. So basically just to say that there are funding options available also if you want to do anything related to next generation sequencing for TB diagnostics. Other than that, you have the Anusandhan National Research Foundation, which comes up with multiple calls periodically. So to end, what I would like to say is, which has already been mentioned in the previous talk, that we need a lot of public-private partnership to ensure that genomic surveillance, TB surveillance becomes a regular activity under the National TB Elimination Program. And but the good news is that it is feasible, and post COVID-19 pandemic, we have lots of facilities which have access to next generation sequencing. So it's not an impossible task to have genomic surveillance for MDR TB in India. So these are some of the references which I have used. Thank you.
Thank you, Dr. Gary. I think, should we wind up for lunch or any one or two queries? I think there is no queries.
So
It is
for
lunch.
felicitation, I would like
you.
to invite Dr. Manoranjan Das to felicitate our first speaker of this session, Dr. Bajanti Mala Mishra. Ma'am, please come on the stage. Thank you, ma'am, and thank you, sir. I would like to invite Dr. Rashmi Ranjan Das to felicitate our speaker, Dr. Shri Nandish RP. Thank you, sir. I would like to invite Dr. Arghya Pradhan, State TB Officer, to felicitate Professor Dr. Manoranjan Das. Thank you, sir. And I would like to invite Dr. Anish Kumar Arimbasari to felicitate our Professor Dr. Rashmi Ranjan Das. Thank you once again, everyone. We now invite all of our delegates, speakers, and faculty members and partners to join us for the networking lunch. We kindly request everyone to proceed there, and we will meet after 45 minutes here for our next session on panel discussion.